90+% of our population is mid-face deficient. And even the orthodontic metrics created in the mid-20th centuries were created on already corrupted heterogeneous populations. If you go back even 200 years ago to the pre-industrial revolution, and you look at those skulls and you look at their measurements, their craniofacial structure is totally different. We have corrupted metrics of what is normal. We've lost our ancestral diet. There's just no way to recover that.
So, Dr. Buck, it's great to have you with me. This is the first time we've ever spoken, but I've been across the work you're doing over in the States. I love that you're doing epigenetic style orthodontics, and it's just such a fascinating evolution of orthodontics and what's possible for people. Why don't you start with how you got down this path of epigenetic orthodontics and away from, I'm assuming it was more traditional dentistry when you started in college back in the day. How did that all change for you?
Well, certainly a long journey. I'm no longer a spring chicken. I'm 35 years in practice, but I still feel like I'm 25, just starting, because you never reach the point where you know it all and you think you can just coast. It's a constant learning and challenging yourself with new information and refocusing and reinventing yourself. So I am a general dentist with many years experience in primarily TMJ and occlusion and reconstruction. And as time went by, I realized that the orthodontics provided a much better solution for craniofacial pain problems and the ability to solve those problems. Alongside of that was early airway training. I was doing oral sleep appliances for sleep apnea back about 2010, one of the first in the area. Well, if you go before that, I was one of the first dentists in Seattle to stop using mercury fillings in 1989. It's still being taught today, and as soon as I got out of school, I started reading some scientific literature that wasn't dentally related, and so quickly became aware in the toxicology arena of the damage of heavy metals and the potential damage and risks associated with amalgam. There's no question you're exposed to it. So that was my first foray into holistic thinking. And then I went on to start or co-found a mercury separation technology company, because for decades, dentists have been dumping amalgam waste into the wastewater and they can't deal with it at the treatment end. So we created a separator that's been accepted worldwide. Now it's mandated, at least in the US, you have to filter that carefully before it's discharged. So for some reason, it's still safe to put in the mouth, but it's unsafe to put in the wastewater stream. That's kind of an interesting paradox there.
Yeah.
So then into occlusion and bonding, naturally, because I was using all non-metal restorations, and then occlusion TMJ, and realizing that I could make such a difference with orthodontics. And one of the most motivating times was, as I was in this journey, I have 6 children. My youngest daughter has achondroplasia, which is dwarfism. And so one of the hallmarks of that genetic condition is mid-face hypoplasia, severe risk of sleep apnea, upper cervical problems, and sometimes cervical issues related to the cranium. And I started on a pathway of working to extend mid-face development with her to, and it was a much, much more acceptable result than traditional ortho. And there's no protocol for helping those children with mid-face hypoplasia. And you can do something. You can stimulate early growth of the mid-face, which is the nasomaxillary complex, even with a genetic predisposition to mid-face damage. And you can overcome that to a large extent. So in her case, we were able to greatly improve the mid-face severely. She doesn't have sleep apnea. She has all of her teeth, no extractions, and a much different looking face than most acons. And people have commented they don't think she's has it because her face is so much different. The typical presentation of achondroplasia is a very suppressed bridge of the nose, very prominent forehead, very suppressed midface.
Mm.
So, and she's my youngest, so I got into ortho progressively from that point about 15 years ago, working more and more. Now, in 2016, I sold my general practice in downtown Seattle and moved to the north end and created a whole new practice just dedicated to sleep, airway, TMJ, ortho, and embracing, because there's so many, I would say, controversies or stagnant things in orthodontics, as you probably are aware of in the United States. There's still a strong belief in extraction based orthodontics. There's a strong motivation to disregard any connection between orthodontics and the airway. There's still this idea that there's not a connection at all in sleep breathing, which is sad because the medical community has embraced orthodontic arch development to improve the airway, because there's very good studies from Guilleminault, who has passed on, showing the connection between arch jaw development and airway improvement. And there's
Yeah.
still a debate about whether sleep apnea has an anatomic origin. And there's a very good paper that was published in 2016 that really demonstrated that all subphenotypes of sleep apnea have one thing in common: craniofacial deficiency.
Yeah.
So if you correct the craniofacial deficiency, you correct the airway, you can ameliorate or eliminate sleep apnea. So for me, my airway sleep apnea training with oral appliances and orthodontics just kept merging together. And the latest, I think, sort of burgeoning evolutionary starting point, or as like a new opening, is the idea of the concept that the earlier we treat, the better we get. I would much rather treat a 3-year-old and have no problems at 18 than try to repair the damage or mitigate the damage at 18 with conventional therapies, right? It just makes sense from the best that we can do for our patients is intervene the earliest.
Mm.
And traditionally, orthodontics has ignored early ortho for the most part. I mean, the typical idea of having a screening examination at age 7 or 8, which is followed by a waiting period of doing nothing until the face is grown, and then intervening with conventional hardware at 13 or 12. All of the facial growth is gone. No attention to breathing, sleep, airway, myofunctional health.
Mm.
And so all you're doing is rearranging the deck chairs on the Titanic at that point, potentially.
Yeah.
So ethically, the best we can do is to start earlier. And there are some novel appliances that are atraumatic or non-invasive, high compliance rate, that can stimulate jaw growth even in the pediatric dentition.
Mm.
So the newest wave of thinking in relation to orthodontics, airway-centered orthodontics, is evaluating 3, 4, 5-year-olds and providing potentially a stimulation appliance to cause arch development, create new bone.
Mm.
Much different than traditional two-dimensional thinking. This is a three-dimensional thinking. You get development fully of the face. And I put a high priority on face-forward development. Everybody focuses on transverse development. Oh, we're going to do transverse, because they don't understand you can do face-forward development.
Yeah.
And so you get a much better result when you do face-forward jaw development. You get better looking faces, you get better airway, you get much reduced TMJ problems potentially, and you get much better posture. The cranium centered over the cervical spine is facilitated by a proper airway. So
Mm.
compromising the airway, immediate compensation by the body is forward head posture.
Yeah. Yep.
Forward head posture sets up an entire compensation pattern going down the spine, altering the entire structural alignment of the spine.
Mm.
And so we think of like we'll come back to this, but I have a comment about aging and posture.
Okay.
So
Yes.
that was a long intro. Sorry about that. I could go on and on. So I'm
You.
going to let you step in and say something too.
Yeah. Well, I love that you're about to talk about anti-aging or aging well, because we'll definitely want to hear about that. It's fascinating that you say, let's start the functional orthodontics with kids as early as possible, like 3, 4, 5, which is exactly when parents are seeing that their kids aren't sleeping well. If they get a
Yes.
virus, their tonsils and adenoid, like the tonsils especially, flare up all the time. And my kids had adenoid tonsillectomies because they were too
Yes.
young. They were too young for anyone to give them functional orthodontics at age 3. But you're seeing that they're struggling to breathe if they get the slightest cold or fever. So you think, okay, well, I'll take the tonsils and adenoids out because I'm desperate to open it up a little bit, knowing it won't be the be all and end all to help their breathing forever, but it's something. So I would love it if more orthodontists would say, yeah, bring your 3-year-old in. There's something we can do now to stimulate a little bit of bone growth. And because, they're little kids, you don't want it to be uncomfortable and too intense in early childhood. But there's a leaf expander or a self expander. Are you familiar with those appliances that can be worn in the mouth and they just, whether they're hooked in and they expand gently on their own without having to take it out and use a key? Is that your suggestion for helping a child who might be 3 or 4 to start opening the arch?
So I think, are you describing like an alpha appliance, which is a light wire kind of constant light activation of force that you wear, but the dentist adjusts it or the orthodontist adjusts it for activation?
Yeah. There's also a Sierra Leone appliance, and it's not very accessible. I've seen it talked about online by their website, but I've never heard of an orthodontist actually using it. And I think the marketing said it was preferable for children who were on the spectrum, who had sensitivities and needed help overcoming obstructive sleep apnea. But due to their condition, this was a tool that interfered less with everyday functioning. And it actually had this little spring that even on
Ah,
its own, it gradually just started to apply that gentle force on its own. But I haven't heard
yes.
anyone using that.
I'm not familiar with that, but I get what they're suing. But that's probably a transverse development rather than this idea of forward development, creating three-dimensional changes. So it's a different. We can talk about it and go dive in deep technically, but um, the interesting thing about what you said is a major study done in the medical side on ENTs for tonsils and adenoidectomy. They showed a high recurrence rate and a less than ideal or quite less than ideal outcome. There's a problem with that. What the problem is the child habitually mouth breathes as a result of tonsillar adenoid hypertrophy.
Mm,
The problem in the medical field is they were doing the surgeries and the child inevitably would continue to mouth breathe after the surgery as
mm,
the habit had developed. That creates tremendous complications, potential postoperative bleeding, contributes to inflammatory problems. So that study in my mind was flawed because you have to have that child primed and ready to do the minimal thing like lip taping after the tonsils adenoids are out to not let there be any incidental open mouth posture
mm,
during the healing period.
mm.
Because as we know, nasal breathing releases nitric oxide, which is tremendously antibacterial, antiviral. So oftentimes when I have a child that has clinical evidence or radiographic or both evidence of tonsillar or adenoid or both had hypertrophy, our first uh, therapeutic intervention is to use lip tape to see whether or not the child can breathe nasally at night without taking it off or having to resort to taking it off.
Mm,
If they can breathe nasally, and we do it in the office for 3 to 5 minutes and observe the child just with the lip tape on to sort of get an initial feeling, but if that child can breathe nasally with the lip tape, the production of nitric oxide should actually cause involution or resolution of that tonsillar. I've had many children where they were slated for tonsil adenoid surgery. We did our myofunctional approach, which is basically not mouth breathing. And if they can successfully nasally breathe, even in the presence of swollen tonsils or adenoids, we'll do a follow up in 3, 4 months, and oftentimes that tissue is resolved or has shrunk significantly.
wow.
So then
Amazing.
they're not needing surgery. So let's say the child has tonsillar or adenoid problems and you put the lip tape on and they cannot breathe nasally. Now you have a situation where you're going to have to probably go to surgery to clear the airway.
Yes. This is interesting because I was skeptical about mouth tape, thinking, oh, isn't it about the tongue being high and developing the palate and they're skeletally too narrow? But you're saying sometimes could the mouth breathing have led to the tonsils being flared up because there's so many pathogens and bacteria coming in? because they're breathing orally. So this flares up.
Yes.
But then if you can retrain them out of that habit and get the nitric oxide coming in and the nasal breathing, this can shrink down the tonsils and adenoids enough that they can keep them, that they don't need them surgically removed. That's fascinating.
Yes.
Okay.
Yes, that's absolutely true. So
Mm,
you're right. Lip taping usually has a myofunctional benefit of beginning to invite the tongue to be in the palate
mm,
because you have a better chance of that. So it's an
mm,
adjunctive aid. You can do other things, like oftentimes we'll use some appliances like the MyoBrace appliances to help with tongue to palate placement.
mm.
But that's a huge area that no one acknowledges. And John Mew, as you probably know, presented the evidence so clearly. He's such an eloquent, wonderful person who's been persecuted mercilessly for years. But his entire basis of his theory and his practice is called the tropic premise, which is that tongue to palate rest oral posture is central to everything. And nothing, in my opinion, could be further from the truth. And it's so absent today in our culture with what's the deformities, or I should say the deficiencies craniofacially we have. And there are a number of reasons for that. And without intervention, without working to attain that tongue to palate, you create all kinds of interesting downstream effects. I even do experiments with patients. If you breathe nasally with the tongue low in the mouth, you'll feel, and you breathe abdominally, diaphragmatically,
Mm.
you'll feel something that's when you put the tongue fully up in the palate and you breathe again nasally, diaphragmatically, you actually feel a much deeper breath just by closing off the oral space, the oral intraoral cavity, because and you open up the lower lobes of the lungs, so the diaphragm is more efficient, and you open up the lungs so that you end up having a slower, deeper rate of breathing.
Mm.
And as a result, you have a natural tendency to build up a higher CO2 level in the blood, which is the key to oxygen delivery. Not having so you have to have some tolerance of a higher CO2 in order to deliver oxygen more efficiently to the tissues.
Right. So there's more air pressure when we breathe nasally, right? When we close the lips, so it's not coming through both routes, it's only coming through the nose. The speed that we can inhale that oxygen, and then the slower diaphragmatic breath, giving the body more time to extract oxygen before an exhale. That's what's going to increase the blood oxygen levels, and that's what's going to make the whole body work in harmony.
Yes, and the tongue to palate creates a greater gradient, pressure gradient that will open up the lower lobes of the lungs, which are not normally open. So
Hmm.
pathologic breathing is almost always associated with a mixture of upper chest diaphragmatic breathe, or upper chest intercostal breathing, which is a sympathetic activator, and
Mm.
some maybe abdominal breathing. And so part of the behavioral pathology that follows sleep disrupted breathing or sleep disordered breathing
Mm.
is going to be sympathetic dysregulation or autonomic upregulation of the sympathetic nervous system.
Mm.
So we do Buteyko breathing re-education and talk to people about breathing, and we do some of the recommend some of the breath holding exercises because you have to rebuild your tolerance to CO2, and you can do it a number of ways, but breath holding Buteyko style is very good for children.
Mm.
And they can very quickly readapt to having a much different breathing, even by, let's say, wearing a MyoBrace for 20 minutes and practicing tongue to palate placement and practicing on diaphragmatic breathing. You're resetting the physiology of breathing and you're activating the vagus nerve, the parasympathetic activation, and you
Mm.
can start to reset the body's physiology of breathing right there.
Yes, that is fascinating. Uh, you mentioned something about, the thoracic chest breathing, the diaphragmatic breathing, and the differences there. Is it just the thoracic breathing in itself turning on that sympathetic response if we're breathing here rather than deep into the diaphragm? Is that alone signaling to the body a bit of fight and flight? Like it's a
Yes,
panting.
yes. So just the intercostal muscles and the upper chest breathing apparatus where the upper ribs are being elevated with the neck muscles, that whole mechanism is part of a sympathetic system activation. So
Mm.
that's like your backup emergency if you're in a fight or flight mode and you need the maximum amount of oxygen delivered in the quickest amount of time. you're going to have this upper chest activation. So that is absolutely correct. So you've got to reprogram the body to not have that upper chest breathing. Shallow breathing though is almost always associated with chest breathing, which is usually a result of sleep issues. So sleep deficiencies, inadequate physiologic sleep breathing is going to lead to shallow upper chest breathing, which is going to lead to sympathetic upregulation, right? In addition to the sympathetic upregulation from disordered sleep breathing.
Yes.
The problem is we have such an underappreciation, even in the United States, if not worldwide, we have this underevaluation for children in sleep breathing. We don't pay enough attention to it. We think of these metrics that relate to sleep apnea in adults, but there's a whole category of sleep disordered breathing that relates to intermittent hypoxias, just short little dips in oxygen that would be of really relatively little consequence to the fully grown adult, but are catastrophic cognitively to have these intermittent hypoxias during sleep for children. And there's not really a very good way to measure that, but we can do that through some, autonomic arousals, and if we do in sleep studies, but there's only like 5 studies about children and mouth breathing, unfortunately, but they tend to agree that around 50% of children mouth breathe in Western culture, Western society particularly, between the key times of growth of the face, which would be between 4 and 12. And that itself is so devastating to the cognitive developing brain, because a child's brain is so much more sensitive to oxygen deprivation than would be an adult, for say, because of the developing brain.
Yeah, people really underappreciate the lack of oxygen to an immature developing brain can have massive consequences for learning and development, how their personality is operating, how a child is flourishing or not flourishing. Do you find children come in with attention deficit and hyperactivity, or difficulty socializing, making eye contact, and I suppose learning like you would typically expect a child to be learning and engaging, because they have an undiagnosed sleep disorder? Is that your experience?
Well, it's yes, although I'm definitely I don't think autism, it's a different animal, right? So attention deficit so closely tied to sleep breathing disorders. Autism being a different entire entity, probably not. So there's a range of things you would expect to see with regard to irritability and anger and inappropriate behavior, obviously cognitive problems related to attention deficit. So you kind of jump that all together in one category.
Yeah.
But I would strongly suspect that even fatigue and weight gain and pre-diabetic states, if you're not sleeping and you're in sympathetic tone and you're secreting cortisol, there's a greater likelihood of improper glucose management, and going to be, weight gain from that standpoint. And sort of pre-diabetic syndrome can be a part of inadequate sleep. So it's all the downstream effects. Certainly cognitively, yes, but there are metabolic consequences as well to sleep issues for children. But I would say the biggest problem is that the developing brain is so exquisitely sensitive to oxygen. If you mess with that, then you might have long-term, maybe permanent damage from a cognitive standpoint.
Yeah. So that's very interesting. And you did pick up that I was alluding to behaviors on the spectrum, and I was sort of lumping them in with attention deficit hyperactivity because I just wanted to see what your thoughts were. And I know they're 2 different diagnoses, but there is a study, I think it's about 3 years old now, and I found it fascinating because it talked about the autistic facial phenotype. And they described this autistic facial type as large forehead, small midface, and a masculinized look. So it wasn't clear whether that means the jaw's a bit square with a shorter growth pattern or what that meant. Maybe it was a heavy brow because of the big forehead, small head. But what they described is essentially a face that's going to struggle to breathe and sleep. And so if you're saying we've got children exhibiting behaviors that look like on the spectrum and they've all got this inherited facial type, is it more that some of the children could just have not structurally developed optimally how they should have, now struggle to breathe and oxygenate well and have restorative sleep and exhibit some symptoms that we may look at and think that looks like autism? I like to keep that conversation open because I wasn't sure about all autistic children having a particular facial type. Mm.
Yeah, there's so much conjecture about autism, and even interesting correlatives with vaccinations and how it's gone up so amazingly, corresponding to the increase in the vaccine schedule, which is now upwards of 60 over the first 5 years of life. So there's a whole bunch of uncertainty and things going on, but that we know the rate's increasing. We know we're within 20 years we might be 1 in 3 children have autism or on the spectrum. So it's could be there's other, obviously people talk about different environmental contaminants as well, particularly the diet being contaminated with a variety of chemicals and things. So there's a whole bunch of interesting
Mm.
conjecture going on. So,
That could impact the
but
brain.
it's true. Yes, I mean, so it's the point being is that the mid face is not developing in our culture now. Very good evidence was presented by others, not myself, that K2 deficiency affects midfacial growth, and maybe very early on. Certainly, we know that the midface. So one thing is for certain, and I don't even understand why do we debate this? Why do we have a controversy? Enlow's facial biology is the best model we have, and no one's refuted it to my knowledge to this date. But the facial bones, the structure of the skeletal facial system does not have a genetic blueprint within it. It's fully responsive to the totality of the soft tissues. Both Moss and Enlow clearly outlined that. Just take all you have to do is Google aglossia, which means horrible, tragic genetic condition where someone's born without a tongue, and look at the damage to the arches in the face. If there was a genetic pre-programmed blueprint to the facial skeleton, then why would there be the complete collapse of that skeleton without in a situation where the person's born without a tongue? I mean,
Mm-hmm.
it's like prima facie evidence. So, the mid face is going to develop by virtue of breathing through the nose and chewing forces, right? And what's going on with the tongue.
Mm.
And so today we've lost our ancestral diet. There's just no way to recover that. People have thought about it. We have a functional appliance that kids chew in. They wear it 24/7, trying to replicate some of that chewing force delivered to maxillary tuberosity. But we've lost that growth stimulation from chewing forces, more or less. So we're left with tongue to palate or tongue action, and we're left with nasal breathing. And it just makes so much sense. When you're thinking about a child breathing maybe 1 liter per minute through whatever aperture, the oral cavity or the nose, the flow of air from a child to an adult goes from approximately 1/2 to 1 liter per minute all the way to about 7 liters a minute, 7 times the volume of air as the lungs grow. That air being delivered through the midface causes that's the signaling for the midface to grow.
Mm.
So we have to since we've lost the dietary influence, we have to maintain the nasal breathing and myofunctional effect of the tongue.
Yes. I don't know whether you have this easily accessible in the United States where you are, but biltong is making a bit of a comeback where I live in Australia. And it's a dehydrated meat. It's a bit healthier and I think more palatable than beef jerky. And it's the best exercise for the jaws. And that's what all of our ancestors ate, this Paleolithic diet, because we couldn't refrigerate meat to preserve it. So we had to take the moisture out, make it brittle and chewy. And in parts of Africa where there isn't a cold chain, there's not a lot of electricity, they're still eating biltong. And guess what? Their cheekbones are big and high, big wide smile, and I'm assuming not breathing difficulties like the rest of the world. So has the refrigerator created a lot of
Yeah.
problems for us? And I don't
I
expect
mean,
people to
yeah,
get rid of the
it's
fridge, but
remarkable. Yeah, so there's so much to talk about. You're right about that. Anything, I like the beef jerky idea, but any way we can give some kind of harder chewing substance, texture of foods, the better our children would be. Well, we have a whole problem of weaning. We have this cultural weaning of toddlers, infants, from liquids to solids, and we typically have semi-liquefied foods.
mm,
Generally, that's the idea, pureed foods or whatever, because there's a mythology that the child could aspirate solid food. That really isn't true.
mm,
It takes about a week, and the child can learn to eat solid foods without making a mess, obviously, but learning to chew and swallow correctly.
mm,
So we make the mistake of this semi-liquid foods, which perpetuates a suckling swallow, and then we also swipe the cheek usually and clean up the mess and put it back in the mouth. Well, that's a hardwired neurological reflex to nurse. So the last
mm.
thing you want to do is swipe the cheek with the spoon of a child eating some kind of food, because you're confusing the brain and perpetuating a suckling swallow, tongue between teeth swallow.
Yes. And do you have any advice on drink bottles or to use straws or not straws? Because parents are confused. Should I feed my child with a spoon? Can I give them the little sippy cup? Are these things disrupting their swallowing and the tongue thrust develops and then there's orthodontic problems?
I think that's partially true. I think, I know that there hasn't been much in the way of nipples for bottle feeding that can simulate actual breastfeeding. I don't think we have any comparable analogous similarity. And so, there are myofunctional straws that are available that we use in myofunctional therapy that can kind of stimulate a correct swallow.
Mm,
But it's a very complicated problem, and that the interesting thing is that myofunctional therapy is kind of hard to get success all the time, because we swallow upwards of 1,500 times a day even while sleeping.
mm,
So how can you ensure that 12 to 1,500 swallows are going to be correct?
mm,
And if you have some swallows that are correct, some that are reverse swallow, it's
mm,
like you have a very strong likelihood of perpetuating that swallow.
mm.
Absolutely. So we use appliances that correct the reverse swallow pretty reliably, actually.
That's fascinating. I didn't know about the correcting swallow appliance. So you've got a lot of tools in your toolbox for myofunctional help for your patients.
Yes, that's one of several tools, but that's one of the things we look at, and we'll use it sometimes independently if we see a severe swallowing thrust to
Mm,
correct that part of the equation. But again, anything we do therapeutically, orthodontically, orthopedically, adults and or children, we have a foundational, the big four, I call it. And what that means is we want tongue to palate, we want nasal breathing, we want lip seal, and no swallowing habits or reverse swallow. Those four things are just key to success
mm,
or a better outcome with treatment. And
mm,
with no treatment, you're going to have better growth, better facial development.
mm,
And again, the face is 60% done growing about age six. So the 40% remaining is going on between 6 and 12 ish. And
mm,
that's the maximum we can get, as we can influence that
mm.
development. The
Yeah.
early face development is largely determined by cranial growth. As the brain grows, the cranium grows, stimulates the face to grow. So up to about age 6, fortunately, we have a kind of at least some help with rapid cranial growth, the cranial vault called the neuroendocrinium, and that's highly stimulative to the face. But if you couple that, of course, to weaning correctly and eating solids and making sure the child can breathe well nasally, um, so much for the better, not only for the sleep, but for the facial jaw growth.
Mm. And so you're treating lots of children. Parents would want to know after expansion, is it okay to use braces? Or when does the child stop growing? Because sometimes there's expansion, but some of the teeth are out of alignment. And then parents are thinking, do I use braces? Do I not? Is it okay to if they've already got enough growth? Do I come back to expansion when they're adolescents because they're doing another growth spurt? It's quite a tricky plan to navigate.
It is. You're right. It is. So we work primarily with a three-dimensional growth strategy using a sagittal appliance, and I can talk more about that. And then we follow it with transverse as needed. The focus, unfortunately, is just on transverse. That's more two-dimensional thinking. Yes, in a child under the age of 14 or 15, you can separate the maxillary mid-palatal suture, and you can get in mass expansion of the upper arch. However, do you get this face forward jaw development, which is the preferred pathway? Well, yes and no, not very much. You can do another appliance that doesn't separate the suture that causes growth. And I published a paper on this. It's quite remarkable. This sagittal appliance, worn, it's removable, causes actual jaw growth, both jaws forward. Bone is ready for widening of the teeth later. So we typically want to work on development of bone first,
Mm.
and then movement of teeth if needed secondarily, not just going to moving teeth. So it's a bit of a difference in approach. However, the research that's there is good that transverse development does improve the nasal cavity and breathing and can ameliorate sleep disorder breathing. So there's a place for transverse development, and it's a
Mhm.
part of our thinking and clinical diagnosis. But we don't want to forego the ability for sagittal forward growth, and then, of course, the myofunctional components as well.
Mm. So, do many orthodontists use the headgear that can attach and pull
Ah,
the top jaw forward? What are your thoughts on that? I don't see many of them using
oh,
it.
no, headgear traditionally, whether it's high pull or cervical, is meant to restrain or retract the
Oh,
maxilla,
not
which we
that
never
kind.
want to do.
No, the bow.
Yes, the
Mm.
reverse pull face mask is really the only treatment conventionally for an underdeveloped maxilla to protract the maxilla, but it's actually fairly not as effective. The appliance that I use, the Witzig sagittal appliance, is actually much more effective. And the case study I published was a class 3, and we had good, with less undesirable side effects. The face mask can produce some undesirable effects on the lower jaw. So the only you don't have just that treatment option for a class 3. You can use a different appliance without using a face mask.
Right. Okay, that's good to know. And you're doing treatment with adults as well. You're helping people still
Yeah.
develop their maxilla and bring the mandible forward
Yeah.
at any age.
Yes.
Fabulous.
Absolutely, yes, that's absolutely true. We have growth, right? Growth is a actual displacement of structures followed by remodeling. Well, when the growth is finished, you have remodeling. That's another misnomer, I'm sorry to say, within orthodontics. I mean, the skeletal system remodels constantly through life. I mean, the bone that you have now is almost completely replaced by about 3 years. You have new bone where old bone once was. So bones are subject to remodeling, and that includes the facial structures as a result of function. Function determines form, or form follows function, but bone can remodel at any age. And so we can effectively harness that to cause there to be positive remodeling changes in an adult. And we can also harness growth, obviously, and remodeling in a child.
Yeah, that's wonderful because I underwent remodeling as an adult. I had really bad asymmetries and I was able to myofunctionally and with orthotropics get the face close to where it should be. I have a lot of adults, though, still suffering, saying, is there hope for me? I've had teeth extracted. I have breathing issues. Should I be expanding? Can I expand at my age? What would you say to someone who's had 4 teeth pulled out, who's struggling with their health and considering expansion? What's the best hope suggestion of treatment?
So again, we can do it, look at it two ways. We can remodel, cause bone to form, and open up extraction spaces if needed to replace those teeth, or we can bring the upper jaw forward, bring all the teeth forward. The lower jaw can be stimulated to follow that and result in a much more healthier TM jaw joint and opened airway. So a lot of my adult patients who have TMJ problems have had 4 bicuspid extraction or 2 bicuspid extraction, and the retraction compresses the jaw joint. Yes, I have patients in their mid 60s and early 70s who are undergoing remodeling treatment with appliances and orthodontics to reestablish a better airway and a better jaw joint position. It's quite possible to do that following these growth principles that are all the way back into Enloe. Really, it's Enloe's work that's the basis of a lot of our thinking in this area. Unfortunately, there's not a lot of agreement there, and so not very many are doing that. And even TMJ, there's a controversy and debate about how you treat TMJ. So it's sad that there
Mhm.
isn't much consensus there. But um, we treat severe craniofacial pain patients. We stabilize them with our appliances in the first phase, and if appropriate, we can use a second phase of specific orthodontic strategies to help stabilize the bite and the joints and often the airway. So we can't prove it, but we have a bunch of different early evidence that if you bring the jaws forward, widen the jaws, you open the airway, which is inevitable, and then you can improve or eliminate sleep apnea. We don't say we cure it, but we certainly can improve it. And I've got many patients. We do the follow-up studies after we do pre-treatment, post-treatment sleep studies, and after treatment, their airway is functioning normally. Or, for instance, they're off CPAP entirely when they
Mm.
were relegated to on CPAP,
I
and then
love
are off
that.
CPAP now.
That is amazing. The health benefits, the life sustaining benefits afforded to people. It literally could be extending their lifespan. And I love what you're doing because many adults approach anti aging with plastic surgeries, which actually can just
Yes,
mask what are serious health complications. So the shrinking craniofacial structure will create those breathing and sleep difficulties. But a person may think, oh, I want to restore my cheeks. I'm going to implant some silicone or I'm going to start plumping up and make the face look healthier. But by doing that, masking and camouflaging what is a suffering system of health here. So that's amazing what's
absolutely
possible,
right.
what you're doing.
Well, there's a follow up to that point. It's very important. Nobody understands this, to my knowledge, but we think of the older person with damaged posture and forward head posture, and they have no neck, they have no chin, and they have open mouth habit, and they're maybe using a walker or a cane. Well, we think that's degenerative changes associated with aging. I would say, in large part, that's due to decades of regressive remodeling. So the point being, if you don't have your tongue in the palate and you don't breathe nasally with lip seal, your jaws will negatively remodel. Your face will continue to drop down and back, which further compromises the airway, which further necessitates compensation with forward head posture, which
Mm.
further damages the structure of the body and the spinal curvatures, and you wind up with pain and limited range of motion and dysfunctionality from the damage, because all chiropractors will tell you this: the bite is the upper block. It's the primary upper block of the entire cervical and spinal system. And if you disrupt this, the entire spinal system can be corrupted.
Yes.
And so
Wow.
if anybody, I mean, it's like, oh, you want to preserve the architecture of your face and not age and have forward head posture. You better work on that tongue to palate placement practice, and if necessary expansion, because it's kind of like, well, if the arch is too narrow and the tongue doesn't fit, there's a certain a point where you have to do some arch development to allow the tongue to once again fit up in the palate where it needs to be. and
Yes.
and you look at photographs quite well done from myofunctional therapists, and just myofunctional therapy alone can begin to change the architecture of the face. That's the whole basis behind mewing and all of the excitement around John's son Mike Mew and his efforts.
Hmm.
And he's right about tongue to palate placement, the power of that on the architecture and the skeletal facial system.
Yes, it's all about function or whether you've lived a lifetime of dysfunction. And I like to
Yes.
think of anyone who's had success as an Olympic champion, they probably have excellent jaw structure, ability to breathe, their postural alignment is straight, and this is what enables them to excel physically and have that athletic output. And we look at them as though they're genetically exceptional. And but most people have, you know, great genes. It's just a lifetime of dysfunction that doesn't express those genes. And when we look at the supermodel on the runway, we think, oh God, they've got amazing genetics. But a lot of it was their development wasn't disrupted. And we're looking at a beautiful bone structure with perfect placement of those
Yes.
features and thinking, wow, they're superhuman. But most people now suffer to express their potential. And then we think we're genetically flawed. But we're starting to
Yes.
realize now how much modern lifestyle has got in the way of us reaching that potential.
So true. I have this picture. I use it in my lectures of the world's, sprinting champion Usain Bolt, the world's fastest man for many years. And there's pictures of him running near the finish line, and he's like nasally breathing in a 100-meter sprint. And all his competitors in lanes, the other lanes next to him, are trying to catch him. They're all mouth breathing at that point. So and then the marathoners, the Ethiopian marathon, the sub 2 hour marathoners, 26 whatever 0.12 miles, they're nasal breathing, and they're running like 5 minute miles for
Mm,
26 miles. They're
mm,
nasally breathing. It's incredible.
mm,
Almost all of us in the Western sort of culture with our corrupted craniofacial state, we can't nasally breathe under high exertional output. We have to
mm,
resort to mouth breathing. But we were born to be obligate nasal breathers, and that
mm,
got corrupted early in our development. And you're right; it's an epigenetic influence that we're
mm.
talking about.
Yes, and these days people are panting to do relatively non-strenuous things. I guess there's the weight gain and being a bit out of shape. But would you say the face has impacted the weight gain as well? If you've been narrow here and mouth breathing for a long time, does that disrupt your digestion, your ability to metabolize? Do you start to have, because you're under stress, oxidative stress, sympathetic overload, does that also mean people start to put weight on more easily because they're mouth breathing and struggling anatomically?
I would think because of the metabolic effects of having unstable blood glucose and high cortisol levels, and then the tendency for storage of fat rather than efficiently burning carbohydrates and glucose. Yes, I think weight, it's the conundrum of there's this sleep apnea problem, then there's weight gain, and people try to lose weight but they have sleep apnea. And it's like, well, if you treated the sleep apnea at least with CPAP, you would have a better chance of losing weight, and maybe the loss of weight would eliminate the sleep apnea, because we know weight gain and fat in the neck and back of the tongue as a part of the major risk factor as well for sleep apnea.
Yes. So compound effect, it's this negative cascade of symptoms once we're diminished here and breathing is disrupted. And if you're having that poor quality sleep and you're not waking up refreshed, it's difficult for people to make a really healthy lifestyle choice because anyone who's had to deal with a hangover or being sleep deprived,
Yes.
you're reaching for sugar to give you a perk, caffeine and
Yeah.
greasy foods, and
Yeah.
your appetite is up. You're wanting some energy in, but you don't have the, uh, I
Yeah.
guess, the energy to exercise to burn it off due to chronic fatigue.
Yeah. This is vicious cycle. Right. Right.
Yeah.
Yeah. So you have to find a way to restore healthy sleep as early as possible, whatever you need to do. So paramount to health and longevity is having idealized sleep if you can. So sleep environment, sleep hygiene, breathing right, and even supplements for sleep to improve sleep can be useful. And I coach on that for patients that we use oral appliances for as a first line treatment for sleep apnea. We also talk about effective supplements. But yeah, you've got to have a high priority focus on the quality of sleep for overall health.
And would you say that would slow the aging process? Because the more we detoxify and repair through quality sleep, um, it's getting rid of the bad cells and developing like the growth hormone allows us to develop fresh, healthy cells. Is that how it works to keep us looking and feeling youthful?
There's pretty good evidence when you look at the sleep research about the nature of sleep. Why We Sleep is a great book that's out there, but non-REM deep sleep, slow wave deep sleep is sleep for the body. And yes, there is regenerative, reparative functions going on. Very important to have that protected. And then REM sleep is literally sleep for the brain. And you need to have that protected in order for you to consolidate memories and file things away and have increased cognitive capabilities. And so
Mm,
people think, well, I can sacrifice maybe quality or quantity of sleep. No, you can't sacrifice either. You have to have both. And there's a
mm,
lot of research showing us that the quality, I should say, the quantity of sleep has gone down significantly from the 1900 timeframe. We're now down to under like around 6 hours of sleep, which is insufficient in most people's understanding today,
mm.
whereas it was 8 or more hours, eight or 8.5 in the early 1900s. For some reason in our culture, with all of the artificial lighting and artificial stimuli we get, we're sleeping now less than we should be, and all of the ill effects. That seems to be a cultural thing. It's not healthy for us.
Yes, that's so interesting. And I don't know a lot about Alzheimer's disease, but is there a link between poor facial structure, especially in old age, a reliance on mouth breathing and sleep apnea episodes, and Alzheimer's setting in? Is that why that's on the increase?
Well, there's a link. A very good research recently found that we thought the blood-brain barrier was almost impenetrable. And in the most recent years, we've realized there's a glymphatic system. The brain has an ability to cleanse itself. You have to get into a certain deeper sleep, and then the brain opens up and fluid is flushed out and exits through these channels in the
Wow.
brain, this glymphatic system. So where there is a cleansing system in the brain to take out cellular debris that needs to be washed out of the brain, doesn't happen unless you get into deep sleep. And if you interrupt sleep, you're going to have retention of that. And they've shown in some models that contributes to these plaque formations, which is one of the hallmark and the disformed proteins, hallmark features of Alzheimer's. And they've correlated higher risk of Alzheimer's with sleep problems. So there is a connection there that's being explored now. There's many other connections of different things. Just oral health, as it turns out, periodontal disease or infected gum tissue with bacterial overgrowth and so on can get back into the brain and cause inflammatory problems in the brain. The basic
Mm,
principle is you don't want an inflamed brain. If you have inflammation in the brain from any source, you're
mm,
risking degenerative changes over time. And
mm.
that even, so anything that's causing inflammation. I mean, people who are overweight have inflammation in their bodies and in their brains and are much more likely to be depressed or have mood problems
Yeah.
as a result of being overweight because their brains are inflamed as part
Mm.
of the process of being overweight.
Yes. And sorry, I'm picking your brain here with so many questions, but it's fascinating. Is this why so many of our youth are reporting anxiety and depression? We've got a big mental health crisis with our young people. Do many of them not sleep well? They've probably had suboptimal orthodontics or dysfunction that's limited their ability to breathe optimally. Would this play a role in inflammation in the brain, which manifests as depressive symptoms?
I do think so. I mean, the modern American diet is so bad as far as promoting health. There's a dietary connection. There's definitely going to be probably a sleep related connection. I don't think the studies have been done, but they need to be sort of what is the overall population wide sleep patterns and sleep quality. But yeah, if you have craniofacial deficiencies and your sleep is corrupted, there's a whole bunch of downstream behavioral effects. Now, 90 from our research where I teach, it's like 90 plus percent of our population is mid-face deficient. And even the orthodontic metrics created in the mid 20th centuries were created on already corrupted heterogeneous populations. Nowhere near ideal. If you go back even 200 years ago to the pre industrial revolution and you look at those skulls, because they've done that with the Penn collection of skulls, and you look at their measurements, their craniofacial structure is totally different. And so we have corrupted metrics of what is normal for the midface, which is the foundation of the face and dictates what's going to happen with the lower jaw, because in literally the upper jaw, it's one bone, right? So the midface is the bone around the teeth, the floor of the orbit, the nasal cavity, and part of the cheekbone. It responds together as one bone. You can't just move a tooth and not expect the entire system to respond. It's
Mm,
one bone.
mm.
And so if you have, we have this corrupted metrics that we don't even acknowledge that there's mid-face deficiency, which relates, right away to breathing issues and potentially sleep issues, unfortunately.
Yes, you're right. It's this 3D structure. We can't treat it as a 2D smile. We need to grow anteriorly forward, have enough height, have enough width. And it's a
Yes.
central structure that's required, it expects impact to remodel and be strong and distribute the mass adequately to have a healthy face. Now, I'm going to jump to one more hot topic while I have you, and that's the connection between poor sleep and cancer formation. And is
Mm.
being in oxidative stress and having poor sleep influencing these really high rates of cancer? What are your thoughts on this?
Well,
Scientifically, of course.
yes. I mean, so you're right about that. I mean, obviously, cancer is a multifactorial
Mm,
issue. It's complicated. We don't have a cure for it.
mm,
Um, we have good therapeutics in some areas and some we don't. And so, obviously, yes. I mean, we've made a connection to increase risk. I think on elegant population studies, sleep, and there is an increased cancer risk for that. And yes, if you have defective or deficient sleep, you're going to be under oxidative stress, as you say, and that's obviously a contributor to ill health and likely to be a contributor to increased risk, at least of tumor formation, in
mm.
my opinion, from what I read. So yes, I think the cancer increase. There's other issues I think related to that are environmental contaminants and so on. We can talk more, but yes, I think sleep again is a foundational issue that relates to cancer, lowering cancer risks.
It's multifaceted, and you did mention the American or the first world diet, the ultra processed diet that we're now consuming, especially with factory farming. Our meat is laced in nitrates, which they tell us is okay because, nitrates are on spinach and vegetables. But when we eat vegetables, we're getting the vitamin C, and a healthy gut microbiome can convert nitrates to nitrites, and everything's fine. But we know now that our factory farmed meat is full of growth hormones, full of antibiotics, and the antibiotics
Yes.
are destroying the gut microbiome. So when we've got
Yes.
the bad gut microbiome and an influx of nitrates, the science is saying that that cannot convert to nitrites. It becomes a molecule related to cancer formation. And because our
Icosamenes. Yes.
right. Right. And so
Right.
this is where people are like, why is meat consumption related to cancer? I'm sure my ancestors ate meat healthily. Well, your ancestors ate more organic meat, and we're eating this toxic factory farmed meat. And it's that connection to the unhealthy gut and the unhealthy cell formation. Is that what you believe is happening?
Yes, and that kind of touches on this point I mentioned earlier about vitamin K2, which has been ignored for the latter part of the last century, most of it, the majority of it. Well, if you eat organic and grass-fed beef and rich grass-fed sort of milk or dairy, you get the K2, which is responsible in conjunction with vitamin D and A to form this particular matrix GLA protein, which is responsible for the nasal septum to remain flexible. So there's a very elegant animal studies with genetically altered mice and K2, and the midface doesn't grow. There's also a tragic a condition called Binder's syndrome, where the mothers took warfarin, Coumadin, during pregnancy, which blocked the K pathways, which was designed for clotting issues, right? It's an anti-clotting agent, but it created a severe midface deficiency known as Binder's syndrome. So in my mind, that those two pieces of information tell me that K2, if you don't have K2 in the diet, because you don't get it from unless you eat Japanese natto, soy natto, or you if you eat factory farmed caged CFAO meats, you're not going to get the precursors K2, and you may well have premature stiffening of the nasal septum and prevent the mid-face from growing forward.
Wow. That is
That's really,
fascinating.
yeah, because it's such clear scientific evidence about what K2 does. K2 is responsible for bone health and calcium in and out of bone, managing that correctly. And K2 is responsible for maintenance of cartilage. And the specific part of the nasal septum that's nasal cartilage is either going to be flexible, able to grow, or perhaps prematurely stiffened and restrain the midface from growing. So others have suggested that connection between K2 and midface growth, which is interesting, and that relates directly to diet and whether or not you can get food from animals that ate very rich green grass. And even Weston Price understood this. He called it factor X before it became understood to be K2, that the rich green grass that cows ate and produced milk and cheese and dairy products and the meat was especially beneficial to those populations that had access to it.
Wow. I didn't know about this. This is fascinating. I knew about Weston Price and talking about the nutrients in the diet playing a role in the health of the facial structure of the primitively living communities. But I didn't know about this K2 or X factor. This is amazing. You're a very, very holistic doctor. You've considered everything that's going on in the body, haven't you?
Well, my interest is reading in medicine and anti-aging. So yeah, I do a tremendous amount of self-study on that area, but it influences my thinking and how I practice as well. Yes.
You're looking at every little tinkering we've done with the lifestyle, and you're like, it's having an effect somewhere. It's showing up as a symptom. So,
Yeah. So we coach people on diet, and a part of that coaching is K2. There's no reason not to take a K2 supplement. They're good ways to get it, but generally speaking, most of us are vitamin D deficient. The one supplement I recommend is an ADK because so many people don't take vitamin D, and it's the population studies they do show us we're very high deficient in vitamin D, which is a major player in so many systems and functions throughout the body. So we recommend the K2, particularly when we're doing growth orthopedics. We want them on K2, which is quite easy to do.
fantastic. And is the type of orthodontic care you offer, is there a online database for where people could find the professionals doing work similar to what you do? Because parents are confused. How do I find a full face orthodontist who's able to help children or adults? Is there a directory online, or what terms are best? Because there's a lot of different wording around this. To do a Google search, what do
I
you look
know
up?
it's well, very early stages, but there is a little bit of a growing awareness and some unique identity associated with airway orthodontics. So if you use the term airway orthodontics, you'll kind of get down a different pathway.
Mm,
Um, I like the work of Stephen Lim, um, the Dental Diet author.
yep.
He has an online presence, and his work really reflects a holistic, total body approach to
Mm,
nutrition and dental health. And he's very aware of these facial jaw growth issues. He's a good resource.
He's
I also
Australian.
like the
Mm,
work. Yes, he's Australian too. Very talented, very
yeah.
well spoken, and I'm
Yeah.
glad that we have that book in the office. We sell it to patients. We have several books we can sell to patients if they choose to want to get further into it.
Yeah.
I like the work of course, the work of John Mew and orthotropics. And so you can kind of dig into that area and get more awareness of what they think and how they approach these issues.
Mm,
Um, there's good work by Kevin Boyd in the United States. He's a pediatric dentist that's done quite a bit of teaching in early airway development orthodontics. So there's a resource there. But there's a group that I'm a part of called the AAPMD, that's a good source of integrative thinking on dental medicine.
okay.
That will be a good start. And if you so now there's one other place too. I was going to look it up for you.
Did you say it was A, A,
So
P
AA,
for Peter, M for Matthew, D for dog? AAPMD?
yes, that's an association that has a tremendous amount of information. Well worth the effort to go to that site for references about dental and Airway. And then there's one other site. I'm trying to think of the name of it here. See if I can pull it up online.
Thank you.
Oh, it's not. Trying to think of the group, but that'll lead you down a good path. Yeah, APMD would be a good start too.
Wonderful. And if listeners wanted to find out more about you and where you are and what you do, what's your website or your social handles? Where do we go to find out more about you?
Yes. So the office of the practice name is Balance Epigenetic Orthodontics. That's a pretty unique term. So if you type all that in, you'll probably get one result, which is us. I have an Instagram page. I think it's Dr. S. David Buck at Instagram. I think that's the way it's. I'm going to pull that up too, just to make sure I have that right.
Yeah. I'll make sure I'll be
It's
tagging
Dr.
you in this so people will find you. Yes.
David Buck, one word. Dr. David Buck is my Instagram page, which I show several examples of the work I do and some of the thinking. So it's kind of more educational than it is just fun stuff.
But I liked your comparisons because you're showing how opening up the dental arch width is having an effect on the midface rather than typical orthodontics of braces is just moving teeth within a small dental arch. You're developing the arch itself. And
Yes,
fabulous.
it influences the nasal cavity. If you do the right kind of arch development, either a child or adult, you're gonna comment. They'll comment to you, "I can breathe better than I ever have been able to through my nose." Wow, that in and of itself is tremendous benefit. Yes, the arch is wider, but I would rather. I would feel more comfortable, more successful having opened up the nasal airway. That's a bigger benefit.
It's health and it's beauty. That's the fantastic part of all this. They're synonymous. You're healthier, you look better.
Yes.
Yeah. Yeah. Wonderful. Well, thank you so
Yes.
much for your time, Dr. Buck. It was such a pleasure to speak with you for a whole hour and pick your brain and just draw all of that knowledge out of you. Absolute honor to have you on the Nurturing Healthy Faces podcast.
Thank you, Katrina. Have a great rest of your weekend. It's very nice to talk.
Thank you. Thank you. Same to you. Okay. Bye-bye.